Noon, and thank you for joining us today and engaging in this critical conversation around gun violence prevention. My name is Joe Saccharin, and I'm a trauma surgeon at Johns Hopkins. And as we look at this issue, the one thing that is top of mind is that in less than a week after the murder of 8 people in Georgia, really honestly shocked once again the conscience of this country. Americans started off their week with yet another reported mass shooting, leaving 10 people dead who were frankly just going about their daily routine. And of course, an officer who responded to that scene dead as well. As we think about what's happening today in the US Senate, this is the first hearing that Congress has had on proposal to reduce gun violence in America. And while not every policy solution is going to involve mass shootings, enacting common sense measures will save lives. And that requires a comprehensive approach that includes a host of measures, such as executive actions by President Biden, as well as funding critical violence intervention programs that will save many lives. In spite of having over 90% of Americans who support expanded background checks, there still remains a chance that the Senate will not pass this life-saving measure that's already been passed by the House. And this is primarily because the Senate requires 60 votes to avoid a filibuster, and the extended debate that is used to avoid bringing measures like background checks and closing the Charleston loophole to a vote. So in our calls for change, we really have to ensure that our institutions are equipped to be able to provide it. And to pass common sense solutions to gun violence, we also must ensure that we end the filibuster. When you think about the families in Boulder and in Atlanta, and in communities all across our country who consistently experience gun violence, unabated in Washington, D.C., in Baltimore, Chicago, Oakland, and so forth, we hear you, and we also see you, and we stand in solidarity and continue to drive action for all that are affected by gun violence. And this is critical because so often we hear and see these mass shootings that are highlighted by the public and by the media. But the reality is that we have young Black men that are being killed on our streets in cities like Baltimore, Chicago, Philadelphia. And it's important that we tell those stories as well. So I'm really, grateful to be joined by this incredible group of panelists for the third and final installment of our data-driven first 100-day series, really discussing how research can inform policy to decrease rates of firearm injury and fatality, greatly benefiting any action taken by the administration to prevent gun violence. And today we're going to focus on public health reform, and I'm really delighted to be joined by experts in the field. Now, as some of you will recall, on our last 2 webinars, we discussed firearm suicide and industry oversight reform. Today, we're going to address another aspect of gun violence, and that's public health reform. So, as I told many of you at the beginning, I'm a trauma surgeon, but I'm also a survivor of gun violence, and I've been really fortunate enough to come together with clinicians all across the country to be able to stand strong and speak loud as it comes to the fact that we are central to being part of the solution around gun violence prevention. And this is where, some of you have heard of This Is Our Lane, and the movement that really united individuals, not just doctors, but nurses, researchers, to come together and say, we have to be part of the solution. We're the individuals that are seeing these patients day in and day out. And so it's a real honor to be here. And I'm frankly joined with just an incredible group of individuals that I'm briefly going to introduce, and then we'll get this started. The first is Dr. Susan Poland, who is the Associate Executive Director for Public Affairs and Advocacy with the American Public Health Association, an organization that champions the health of all people and all communities, combining a nearly 150-year perspective, a broad-based member community, and the ability to influence policy to improve the public's health. The next is Ms. Colleen Creighton, who is the Chief Executive Officer of the American Association of Suicidology, an organization dedicated to promoting understanding and prevention of suicide and supporting those who have been affected by it. The third is Dr. Chetan Sathaya, who is not just a pediatric trauma surgeon, but also someone who has been funded by the National Institutes of Health for Fire Injury Prevention Research. And he serves as the director of Northwell Health's Center for Gun Violence Prevention. And last, but definitely not least, Dr. Kai Hunter, the Sarah Brady Fellow and a Marine Corps combat veteran who currently studies suicide prevention in military and veteran communities in her role as assistant professor at the U.S. Air Force Academy. Welcome to all of you. It's so wonderful to have each of you with us. So without any kind of further ado, let's get this show started. And we're going to start with Dr. Poland. You know, your organization, the American Public Health Association, has long led the discussion to reframe gun violence as an issue of public health. So can you tell us a little bit about what this means to address gun violence as a public health issue? And why is the approach so critical?
Thank you. I'm really pleased and honored to be part of this panel. Let's start with, we all know the stats and we all know the bottom line is that too many people are dying or injured due to gun violence. There are too many people living in fear of gun violence. Today is unfortunately another day where we are all dealing with the aftermath of a violent attack on people, as you said, just going about their daily business. So the financial and the human toll is astronomical. We know that easy access to guns doesn't protect us. It actually makes us less safe. We know that gun violence is a leading cause of premature death and claiming the life of far too many young people. And we know it's preventable. It's not inevitable. And with the right policies and programs in place, we can make a difference. So what is the public health approach? We focus on populations. We don't focus on the individual. We move upstream to look at the root causes. We try and address gun violence through policy and systems change that's science and evidence-based, and we use a trauma-informed and responsive approach. Public health is known for its ability and its work used convening and relationship building. We focus on the collective, and as I said, we move upstream to the root causes. And so to do this, we know that we can't do it alone. We need to work together with a number of different sectors who are also involved in what some of the core issues are that are causing gun violence in communities. We work with education, with housing, with employment. We overlay that with efforts on advocacy, research, practice, and community engagement so we can address gun violence in a comprehensive manner. It's not happening in a vacuum. It is happening because of a series of upstream factors that we know are critical. But we do this all in a science-driven approach. Part of the issue right now, and one of the solutions, is that we need to have better data. And I applaud all of the people who are funded, but the amount of funding for gun violence has gone down, gun violence research has gone down dramatically. And so we need to have better better opportunity to understand this issue and to be able to create and find the evidence. And when we're talking about public health, as a basic tenet of public health, we think about prevention. We think about primary prevention before the problem happens. So we want to make sure that we have all of the issues related to treatment when gun violence is an issue in place, but more importantly, we want to stop the gun violence before it happens. And to do that, we have to think about some of the risk factors and communities that are creating gun violence. And it's not just an issue of the mass shootings, the shootings that we've seen in the last couple of weeks. It is the deaths of despair. It is I know we'll talk more about suicide. It is these kinds of issues that we really can think about moving upstream But we have to do it in a way where we're not just talking about, again, what's happening with that individual. We need to think about this in the context of equity and access to services and access to opportunity and access to all of the things we know can make a community healthy. In public health, what we do is we put stories and faces into place to understand not just who the perpetrator is, but more importantly, who the people are who are impacted by the gun violence. And it is the immediate victim, but it is also the family and the community. And that is a very important piece of the work that we do, is trying to understand how all of these pieces fit together. As I said at the outset, gun violence is not inevitable. It can be prevented through a comprehensive approach that really thinks about families and communities and really begins to look at some of the specific concerns and issues that we know are in place. So a public health approach to preventing gun violence recognizes that violence is contagious. And we need to think about this as a communicable disease. And it is happening in communities and it is happening across the country. It is at a point where it's an epidemic within our society. So if we're talking about primary prevention for an infectious disease, then we have to think about is how do we interrupt the transmission of violence? We have to conduct the surveillance so that we're tracking gun-related deaths, and we have to understand in a much more comprehensive way what that looks like. We have to identify the underlying risk factors associated with gun violence. So it's, as I said, it's those social determinants of health. It is those upstream factors, poverty and depression, and then look at the associated resilience or protective factors that we can put into place against gun violence, like assuring that youth have access to trusted adults and that they have opportunities that are beyond just the immediate concerns that they're seeing on the street. We need to develop and implement interventions to reduce the factors and build resilience, which will require an institutionalization of these prevention strategies. Bottom line is we know that prevention doesn't require predicting what's going to happen for one individual. We can't predict which individual is going to be happening. If for the COVID pandemic has taught us nothing else, things are much more random than we think. And so just as we are dealing with in COVID and as we're dealing with in whenever we put in regulations in place, it's not to impact the individual, it's to impact the community, to create safer spaces and prevent gun violence in communities across the country. So with that, I will turn it back to you, Joe. Thank you so much again for this opportunity.
Yeah, of course. And, you know, Dr. Pullen, as I'm listening to you kind of describe this public health approach, you know, what's clear to me is that this is not the first public health problem that we have faced in this country, even when you think back to how we dealt with other, disease processes like motor vehicle fatalities. And I think really, what we're starting to see is a reframing of the conversation to then allow us to do some of the things that you talked about, which really kind of changes the approach of simply trying to focus on human behavior, which we know is frankly not cost effective even in and of itself, and developing a system that makes it less likely where folks are going to be injured. And you touched upon, the suicide piece, which is so critical. And I want to bring in Ms. Crane into this conversation, who again, the American Association of Suicidology has really been on the forefront of suicide prevention for at least 50 years. And your recent work has sought to ensure that suicide prevention is made more equitable for all communities, partnering with communities of color and groups to better meet their needs in their space. As we know, suicide is the second leading cause of death for Black youth, 10 to 14, who are also experiencing disproportionate rates of gun violence in their lives. Do you believe that our current public health system is equipped to address suicide in these communities, especially given the daily toll of trauma that they experience? And what type of reforms do you think may be necessary to ensure that we're providing equitable access to care for individuals in crisis?
So first of all, thank you so much to Brady for recognizing the correlation or the relationship between firearms and suicide, because for the longest time, I don't think anyone was talking about suicide. It was kind of just something you didn't mention. And also with gun violence prevention. And so Brady came out strong and said, let's talk about these two together. So huge thank you from our field for making this happen. Are we ready? Absolutely not. Can we be? We should be. I'm hopeful that we can get there, but we have a lot of work to do in order to get there. Coming from the field of suicidology and suicide prevention, historically, it's a very, very white field. If you look at a lot of the research, if you look at a lot of where we've come from, it has not been the most inclusive space. We're working now to change that. And there's a lot of different ways we could get into what we're doing there. But it's not happening quick enough. So I think, and this is something where we say suicide is everybody's business. Everybody has a role to play, including all aspects of the public health spectrum. Now, some of the ways that we can do better, number one, data. If you look at the national suicide data, we rely on CDC data that comes out 2 years. So there's a 2-year lag to when we realize where we need to be, but it's more like where we should have been, and which isn't acceptable. So if COVID and this pandemic has taught us anything, it's really understanding that we could get there. We just need a better national data reporting system. So that's one of our huge asks. I think the other thing that often we misstep is assuming that because we have a national approach, that it's applicable to every community out there. And absolutely couldn't be furthest from the truth. It's not just let's scale this. This is one effective method. We really need to make sure that whatever we're doing, the community needs to be involved. So it's definitely involved like a community-based approach, but also include, maybe culturally representative too, to make sure that we're including those voices in those that we're trying to reach. Like I said, it can't just be like a one size fits all, just scale it across the country. The other thing I think too is access to care. We do not make it easy. It's easy to say, here's the hotline number, reach out if you're struggling. But then what do you do outside being able to call? We realize that most of the country does not even understand the role of crisis services around the country. They don't understand, what happens when you call that number. What does it look like? Now, for AAS, we accredit and we represent the more than 700 crisis centers around the country, including the National Suicide Prevention Lifeline, Crisis Text Line, Trevor Project, Veterans Crisis Line. But outside of, how does the system operate once you call that number, they don't understand. They don't understand the role. And then how do you? Insurance is expensive. If you can get past that barrier, like, is insurance covering my therapy session? How do I find a therapist? How do I find a therapist that looks like me, has gone through some of the experiences that I've had? So I think on that end too, representation matters, and ensuring that clinicians feel supported to be able to see patients who are suicidal or suffer from suicidal ideation or are struggling, or they need to feel comfortable. They need to be equipped. We need to make sure that we're providing the clinician aspect and what they need. Also, medical too, as well, that, our emergency rooms and departments are equipped for everything that they need to be able to handle the issue. But on the other hand, we need to make it a lot easier. We need to remove a lot of those barriers and access to care, because it shouldn't be that difficult to find a therapist to get the help that you need. So I like I said, I'm optimistic that we can get there, because thanks to groups like Brady, thanks to everyone around this table or around this room, that we are having this conversation and we're bringing it out into a more public space to say, we're falling short of where we need to be. And this is what we need to do.
Look, I think that's very well said, and I think you really highlighted both how the delta is large, but there is kind of hope, and we can get to a place where we're really doing a better job at trying to address this, real significant kind of problem as you look at the entire kind of space of gun violence prevention. And I think one thing that sometimes gets lost around suicide is the fact that most people that survive a suicide attempt don't actually go on to die from a second attempt. And when we look at, and we'll talk a little bit about this with Dr. Hunter, but when we look at like the case fatality rate and how the method is so critical to ensuring that, number one, we can get people through this if they do attempt suicide, but even think about it, from a preventative perspective is so critical. So, thanks for all the work that you're doing. And I think Brady, you're right, has done a tremendous job of really, saying to people like, listen, like this is a significant area of focus. And I think sometimes people try to say, well, suicide, has nothing to do with gun violence. And we know, in fact, it does.
And that just really quickly top on, it's more than most. It's like 90% of the folks that, survive an attempt of taking their own life. So, I mean, we definitely need to do better.
Yeah, well said. Well, I want to get to Dr. Sathaya, who, like myself, is also a trauma surgeon and has direct experiences with gun violence. He happens to be a pediatric trauma surgeon, and he also leads Northwell Health's research and heads up their center, and was one of the first recipients for the federal gun violence prevention research funding that, as I think many of you know, was the first time it was funded in over 2 decades. Can you outline for us, the We Ask Everyone initiative, and focusing on how this study is a public health reform approach to address gun violence? And what are your findings so far in speaking with patients about their firearms kind of indicate, and how do these findings lead to the prevention of, what we call family fire, and we'll talk a little bit about here shortly?
Yeah, absolutely. Thank you so much, Joe. Thank you to the panelists. Thank you to Brady for really making this a focal point. I have to say, Brady has done such a wonderful job with really harnessing the message that this is a public health issue, and to the point that they're very involved actually in our research in helping us to normalize this conversation when it comes to physician and patient about firearm safety. So, to answer your question, just broadly, I think it's important to keep perspective in that firearm injury and mortality prevention is almost akin to a new disease, right? Because of the lack of research funding that has been there in the past and the lack of good high quality data, there are so many unanswered questions when it comes to the public health approach. That includes uncertainty about surveillance, risk factors, implementation strategies, evaluation strategies. We're missing buckets in literally every area. So that is just to stress the importance of the funding that you all and Brady have worked to lobby for us. I think it is really the start of how we're going to take a public health approach to this issue. When it comes to the We Ask Everyone initiative, which is really part of our research project, the goal there is to implement a health system-wide, because Northwell is the largest health system in New York, a health system-wide, we ask every patient kind of approach about firearm safety and gun violence risk. So our intention is to have a conversation with every patient who comes into our health system, not only about questions related to access for the purpose of firearm safety counseling, but also questions related to gun violence risk so that we can provide appropriate referrals, resources, community resources, and so on. Hospital-based violence intervention program is a big part of that. The universal approach is kind of the key element there. We in the healthcare industry have preached for decades that this is a public health approach, public health issue. But very few physicians actually ask patients questions related to firearm safety. We have not been able to really make that change. We have not been able to catalyze forward. So one of the approaches that was used with HIV, it was used with substance use as well, was this universal type approach that can remove the stigma of asking, can normalize the conversation, can humanize the conversation, and really try to identify what those barriers are. Because when it comes to physicians talking to their patients, there are many barriers when it comes to talking about this sensitive issue. Just like many of you who are watching have had a conversation around this, I'm sure, with family members. It's not an easy conversation to have. So that's what the study's aimed at. It's really in its infancy. We just started in September. So we don't have a lot of that data initially. We hope to roll that out soon. What have we learned so far? We've learned that even educating our own employee workforce and the healthcare workers themselves in itself has many barriers, a lot of hesitancy, a lot of discomfort. And I think it's really a wake-up call in the need for us to kind of reset as a healthcare industry, take a step back and learn how to have that simple conversation. Because to your point, this is a public health issue. It is not a polarized one. This is not about the Second Amendment. This is about safety. and prevention of violence risk. And to your point about family fire, I mean, we know that physician counseling, healthcare worker counseling, clinical team member counseling can lead to positive behavior change when it comes to storing weapons safely, and really plays into the family fire campaign nicely.
Yeah, look, I think that's great. One of the things that we have noticed is that there are so many barriers that exist as to why clinicians, and I kind of even take it outside of just simply physicians, because there are so many non-physicians that touch patients, why they don't speak to their patients about, concepts like safe storage of firearms. And what's interesting is some of it has to do with their own knowledge and comfort level. Did they grow up as a gun owner? Some of it has to do, as you alluded to, the sociogeographic kind of culture that exists. So I think it's really interesting to kind of, I know you're still at the beginning of kind of this project. And as you start to collect the data, it's going to be very interesting to see where all of this goes, because I think one of the things that so many of us have been really, trying to focus on is how do we empower clinicians with the knowledge and the skills to be able to have these discussions in a way that is objective, that's, not judgmental, and that allows us to simply save lives. I don't know if you can speak to some of the initial things that you may have seen or may have not seen, but would be curious to see if you're having some similar experiences to what we found.
Yeah, I think that's, we're having the exact similar experiences, and, how are we going to overcome that? And I think, to your point, education is the first step. We are learning a lot about the process ourselves, so it's kind of a collective mission. And I think education is the first step. And I really think the universal component will be interesting, because, you almost remove the clinical decision point to screen or not to screen. And by removing that, patients eventually get the sense that this is just a question that's asked, no different than other injury prevention questions. And the hope here is that these questions become part of routine care. I ask you about your blood sugar, just like you mentioned, motor vehicle accident stuff, and then firearm safety.
Thanks so much. And I just want to make sure, I know we've used the term family fire, and I just want to make sure that for everyone that's listening to this, we're very clear about what that means. So family fire is a shooting involving an improperly stored or misused gun in the home that results in death or injury. And actually, our next panelist, Dr. Kai Hunter, was extremely involved in spearheading this effort, and I'm sure can talk a lot more about this. So Dr. Hunter, let's kind of get in and pick your brain on a few things. Clearly, you wear so many hats, right? You're a veteran, you're a Sarah Brady Fellow, you're a professor in the Air Force, and you bring insight, I think, to various ways that gun violence intersects with distinct populations. As we look at the veteran population, for example, we know that veterans, right, only 8% of the overall population comprise 18% of suicide deaths. And of the 17 veterans who die by suicide every day, we know that nearly 70% will be by gun suicide. So can you tell us a little bit from your research, maybe outline some of the indicators that place veterans at higher risk from death by gun suicide, and maybe some public health solutions that our healthcare systems can really implement to ensure that we're doing a better job of taking care of veterans?
Yeah, absolutely. And I want to echo everyone in just, thanking you for moderating this, and to Brady for putting this together, because it, as every single panelist so far has said, like, the time is beyond now. We seem to be having to talking about this a lot, and really framing it as a public health discussion is important. And I think that if we look at veterans as a population, that there's some unique risk factors, but then also some important approaches that are there. One of the biggest unique risk factors that exist around veterans is that we have a very different relationship with guns than the civilian population, and than most of the civilian population. And that's really twofold. One, for many of us, the lethality of guns is not theoretical at all. It is very, very real. And I think you hear a lot of this rhetoric around like, oh, I could defend someone, or I could defend my family, I defend myself, without actually understand that that means an engagement in taking a human life. And so for many veterans, especially those of us who have spent significant time downrange, it's not a theoretical discussion anymore. We're very aware of the lethality of firearms. And then that's coupled with the fact that for a good portion of us, again, we have a very close relationship with guns, and the fact that like it makes us feel safe. As a Marine, your rifle is the most important piece of gear that you have. It is, and we actually, when we go out and train, we talk about it, it's weapon gear self in the order of how you take care of things. Like you take care of your rifle before you eat. And so, so this is a tool that has a lot more symbolic meaning to us than I think a lot of the civilian population. And so that means that we have to approach veterans and approach conversations about lethality of guns in different ways, because we know they're lethal, but they're also very important to us. Veterans also have, despite the fact that we are very big in to safe storage and engagement, that way on our, like in the work side of our lives, we have horrible practices when it comes to actually storing them safely at home. A big part of this is if you get into just sort of the risk factors and risky behaviors that veterans want to engage in, they're high. They have a higher prevalence for taking risks in every aspect of their lives. And so there's this sense that like bad things just aren't going to happen to us. And so the approach needs to be, I think, more focused around, again, not this is a thing that might hurt you, so you need to lock it up, but conversations around how you are continuing to protect and look out for your buddies, how this is part of your continued mission of, safety and service in that way. And I think that adds into some of the public health approach and a lot with what Chetan was talking about here in taking a whole sort of provider approach. And I'd say not just talking about firearms, but your assumption as to who is and who isn't a veteran. And this is where when we see a lot of veterans falling through the cracks and we see this high rate of suicide, one of the things that's also very prominent in the data that we have is that it is primarily veterans who do not use the VA for their healthcare. The use of the VA actually has a very strong protective effects, in particular for women veterans. That's a whole nother side of it. But a big part of it is that conversations around firearms and access to lethal means are just obvious there. Like they are actually very good at having these conversations. When I walk into my civilian healthcare provider, they don't ask me any questions about being a veteran at all. There's no assumption that I am. And that's how I think we have a lot of veterans falling through the cracks, is that they're not willing to engage in these conversations. And still, over 40% of the veteran population doesn't use the VA for any services. And about 80% use a blend. And so when we're talking about the public health approach, we need to also talk about the starting assumption being that everybody owns a firearm who comes in, and that everybody has an experience, a veteran type experience. And if you start that way and then move away from it, you're going to actually catch people in the net. And when we're talking about programs like End Family Fire, one of the things that's really important about this program is that it does take a really 360-degree look at educating people about the risks of unsecured guns in the home, and educating it from the going in point of unintentional shootings. 8 kids a day still getting unintentionally shot by a gun that's found in their home, and now into suicide. So there's multiple entry points. It's very hard to come in and talk to a veteran with the idea of saying like, well, we want you to protect yourself, because we are not designed to think that way. It is like trained out of us completely to think about ourselves first. We think about everybody else first. So having tools that allow for the conversation in some more indirect ways, in more broader broader engagement, part of like your whole safety of your friends and family and those around you, are incredibly important, especially when we're talking about this population. And then I think the other really important aspect of these broader education discussions is to depoliticize the conversation. The veteran population in particular, again, there's a lot of backlash among veterans about being used as political pawns. I mean, we saw it a lot in both the 2016 and the 2020 elections, of this fear of like, we're human beings, we're not political pawns. And so moving the conversation into one of continued service, safety, looking out for those around you, and away from the politics of what we're going to do to control how you can actually access things is another essential part of this conversation. And to the point of making this a public health approach, how are we protecting that population? And that really being our primary focus.
Dr. Hunter, I just want to, that's a fantastic kind of overview. And I was hoping maybe I could just quickly follow up and just ask you, you've been in this space for a while. Can you maybe just give us an example of like, what do you think have been some of the most effective strategies in some of these conversations that you've had? And how much of that effectiveness do you think is related to the fact that the message is coming from someone like yourself, who is a fellow veteran? Does that make sense?
Yeah, absolutely. And I think one of the effective strategies, and this hits on something Colleen was actually saying around, access to therapy and care of people who look like you or who you resonate with. This is a big part of it in the veteran community as well, is access to care professionals that have similar experiences, because I think some of it is the vocabulary there. So I think when we look at what's effective to get at this, it's that shared experience. And so being able to talk to the importance of lethal means as someone who doesn't just research this for a living and work on like program evaluations for a living, but who is a survivor, who has, is here today because of a friend who was willing to have the hard conversation with me when I was experiencing suicidal ideation. But it's because they look like me and had that same experience. So I think having people, when we look at success, that can speak our language essentially becomes important, just in terms of like, when we look at where successful programs are, where successful engagement is the sense of being able to speak openly and frankly about this conversation works. When we look at, particularly for this population, the not sugarcoating what it's going to be, because again, we know lethality is, we know how lethal guns are, and they're just as lethal against us, which is honestly why veterans often choose them. And I think that's one of the things that we have to bring into this conversation when it becomes important, is not sort of tiptoeing around the idea that guns are the most lethal means when you go to attempt suicide. And that's often why they are chosen, because people want that lethality. And I think for a population that is so understanding and has lived the lethality of these things, it's essential that we have frank conversations, that we bring more people who have worked with guns their entire life, professionally in particular, into this conversation, and that we help to empower and have access for mental health professionals who have been in this space too. So we can go, I mean, for me personally, I'll just speak again from my experience. If I sit down with a new therapist and I have to spend the first session like spelling out every acronym of anything I have done in my life, I'm already lost in that world. And I think this is the same with any potential, any higher at-risk population. We want someone with that shared and lived experience to actually be able to help us work through this.
That's so true. And I think, one of the things that really resonated as I was listening to you is the fact that we need to be willing, I think, as a community, not just within the veteran space, but just in society and community in general, to be willing to have these tough conversations. It's one of the things when I think about, extreme risk protection orders, or some people call it red flag laws. those type of, pieces of legislation in my mind are so critical because it empowers, essentially your family and friends, the people that know you the best, to be able to potentially, intervene. And when you think about, and again, Colleen can speak to this a lot better than I can, but when you think about when someone, makes the decision to attempt suicide, from that point till the first attempt, 70% happen within that first hour. So in a lot of ways, there's all these warning signs that we have to think about even before that to really be able to be effective. So I think those are such great points. Do you want to add anything to that, Colleen?
No, I was just going to say to normalize the conversation is what you're saying, and just make it, don't make it an uncomfortable conversation, just make it the norm. And I think we all have a role to play in that.
Yeah, exactly. So look, I have, a final question for all of you, and would love to just kind of go down the line. We'll go in the order that we started. As we all know, right, there's a new administration in the White House, and I'm hoping that maybe you can provide, the folks on this call, maybe one or two steps that the administration can be taking to prevent firearm injuries and fatalities in line with public health reform. And maybe we can start with Dr. Poland.
Data. They can support dramatically increasing access to data and adding questions to the existing surveys and doing a better job with the death reporting data, the violent death reporting data. There's so many different places where we have huge gaps in our understanding of where the problems exist. And the other piece I'd say is financial support, create a public health infrastructure that can deal with the upstream problems and the social determinants, so that we are creating healthier communities. We are reducing some of the infectious nature of gun violence. We are reducing the deaths of despair. We are giving people opportunity.
Yeah, I mean, I think there's a couple things when I hear you talk about that. The first is, I think in general, when we look at the country as a whole, the data is for sure so critical. And I would say it goes far beyond simply looking at the data as it relates to just fatal injuries. And in fact, when we look at non-fatal injuries, the numbers conservatively are 2 to 3 per death a day. And those numbers are conservative numbers because depending upon, as you know, the state that you're a part of or the institute that you're a part of, you may or may not, collect the individuals that say come in with a flesh wound. And that's such a critical group of individuals because when we think about recidivism in our communities, right, it can be as high as 50%, sometimes even higher. So there's an opportunity that exists there that we really have to, I think, have a broader platform of understanding these numbers. So I really appreciate that. And of course, the structural, I mean, when you talk about this from an infectious disease model, really what we're talking about is structural violence and how all these pieces are so dependent upon so many of the different, things that exist within cities across the country. Ms. Creighton, you're next. What do you think?
I'm going to jump on the data bandwagon again, but more real-time data reporting, because 2 years is far too long of a lag. So we really need to close that gap as far as possible. But I also think funding our crisis services at the level that right now they're so underfunded. I mean, a lot of centers are barely keeping doors open, are barely able to meet what they need. So adequately funding the system, and then also just normalizing the conversation, like we said earlier, having that voice at the executive branch or at the administrative level, having more people come out and either talk about their own struggles or just come out and say that, that they're willing to talk about suicide, about gun violence, could do a lot of good.
Perfect. Thank you. Dr. Sataya.
Yeah, so to echo that, I mean, I think, like we said before, that the research is critical. So we need more funding for that just to even have the basic elements of the public health approach. I totally agree with the real-time surveillance thing. We just don't even have a good measure of surveillance, even for non-fatal firearm injuries, to your point. So I think that's huge. And then the second thing would be really putting a comprehensive plan together as to how to incentivize hospitals and the healthcare industry to act on this issue. You know, we're talking about it, but there are a number, you know, the majority of the healthcare industry is not behind necessarily acting on this or prioritizing it over, not even over, at the same level as heart disease, cancer. So I think figuring that out, whether that be, you know, reimbursement for violence interrupters, you know, better reimbursement for even coalitions with gun owners, as to how to normalize that conversation, that kind of thing, I think needs to be looked at.
Yeah, that's great. And I would just say that, you know, even outside of the healthcare systems, you know, businesses within communities have a vested interest to be part of the solution and to invest in, you know, this kind of multifaceted approach that's going to be required to actually make a difference and move this needle forward. So thank you for those comments. And of course, Dr. Hunter, love your thoughts on what you think the White House can do to really help address this.
Yeah, absolutely. I think first and foremost, and it's been moved around, is investment in real research. We've lost a generation of researchers with this, and the result really has been that we have the conversation has devolved into one just based on emotion on both sides rather than real evidence-based research. And I think what's come up time and time again, you know, when we actually have a good public health approach to a problem, you know, whether that is heart disease or car fatalities, we have it because there is a, you know, a community of academic practitioners and advocates that are all drawing from the same song sheet that shows, like, look, it doesn't matter how you feel about the issue, this saves lives. And we've been lacking that. And I think, you know, we saw this with COVID. Once we started to actually adopt no, look, these practices save lives, I don't care how you feel about it, we started to see, you know, deaths go down. We need the exact same thing here. We need to start with the focus on, let's build that community, let's invest in that community, let's take the time to actually invest in the evidence, and so that we can say, I don't care how you feel about it, here's what's going to save lives, and let's do that.
And Kai, you know, as you talk about this, you know, multidisciplinary approach and really, you know, private-public partnerships, I mean, I think this is one of the reasons that clinicians were so incensed when the NRA essentially said that we didn't have a role to play in this. Because the reality is for anyone that understands the complexity of this public health problem, they realize that there is no one person or one organization that is going to be able to solve this issue on their own. So it really requires all of us.
Yeah, absolutely. And I think it's you know, that federal research funding is what's going to help to build those partnerships in a real meaningful way. And so that we're building interdisciplinary teams to solve the problem.
Okay. And I know Dr. Poland had one final kind of idea and comment. Can you share that with us?
Yes, they can use their bully pulpit and move legislation forward. I mean, we know what's happening in the Senate, that we have real common sense policy that's not going to move unless somebody pushes it. And it's got to be, the administration can really help us advocate, get their people out there talking about the problems that we're seeing, the concerns that we have, the real day-to-day impact that gun violence is having, to move these common sense policies forward at the national level.
Fantastic. So I'm excited to have the chance to introduce the president of Brady, Chris Brown, who needs no introduction, but she is going to really close us off with some final thoughts and points. Chris?
Thanks so much, Joe. And I'm so sorry that I wanted to be on earlier to hear what I understand and know from our team was an incredible panel. Thanks to Kai, who obviously has a special relationship with Brady, Dr. Hunter, and all that she's doing. To Colleen Creighton, thank you so much for joining. To Susan Pollan, to Joe Saccharin, Dr. Saccharin, and to you, Dr. Chechen Satya. I hope I got your name right here, for joining us and for helping us really help everyone understand the role of public health in this space and what we can do to transform the conversation around gun violence in America today. I think the opportunities honestly are endless. And for those of you, all of you on this call and listening, for those on the panel, they have been leaders in really helping make sure that this administration understands the role that healthcare and that a public health approach can have to the prevention of gun violence. So I want to thank you so much for participating. Obviously, this moment is very auspicious for us. And like so many others that preceded, it honestly gets very old to even talk about this and to reflect on the moments in time where we're all removed by very little. For those of you who are physicians, who are in trauma centers, we know what you experience, and thank you for This Is Our Lane for sharing that with us. But for the rest of us Americans, we also know how we feel about this issue. And we've had enough. But even last night, watching the wrenching coverage of this is numbing at some level, upsetting, because and you've talked about this is preventable. And so families, the first responder, the police officer who is the father of 7, who lost his life, that didn't need to happen. None of this needed to happen. There are people who were shocking. And so ultimately, the way we think about this at Brady is, how can we focus on this as a public health issue, and what do we need to do to solve this? And so this conversation, I think, was hugely important for us to understand. There are public health components to this, and what we need to do. We need to better fund crisis centers. We need to understand how we can really make a difference around, people who are potentially at risk. We need more research. That's very clear. And we need a public health approach to this that actually really invests also in the education of those in the medical community. We're at a unique political moment in this country where we have a gun violence prevention majority in the House of Representatives, clearly in the Senate, and also we have a leader in the White House who really cares about this issue. The House has done its job. Now it's time for the Senate to do theirs. So they've passed 2 bills to expand the background check system, the House of Representatives. We want the Senate to act, and I understand this is not a political conversation, but I also want to encourage all of you on this phone to really raise your voices to help the policy changes to happen that need to happen, that are the undergirding, the foundation for the rest of our system. And that is HR 8 and 1446 that passed the House, that are now pending in the Senate. Because let's face it, gun violence is a public health crisis. Honestly, it always should have been treated as that. But I just want to say I'm so grateful that Brady is joined by the experts we have on this call from Northwell, from This Is Our Lane, from the American Association of Suicidology, the American Public Health Association, and Dr. Kai Hunter from the Air Force Academy, to champion public health solutions to ensure that not one more American has to live in fear for dying by gun violence while going about their daily routines. This, to us, is a basic American right. Can I walk down the street? Can I live my life? Can I pursue life, liberty, and the pursuit of happiness without the fear of being shot? If the answer to that is no, then our country owes something more to you. And that's where you all come into play. Please raise your voices, support the work that we're doing, and help those who are doing so much, who are part of this panel today, really make a difference. They're the ones who are really on the front lines, truly, of making a difference on this issue. Thank you so much, and I'll direct back to you, Joe.
Well, thanks so much, Chris. What a perfect way to close. And I think you hit the nail on the head. And thanks to all of you for joining us this afternoon for this conversation about how we can really provide more of a public health approach and a public health reform to this issue. I think it's really through these data-driven conversations that we're actually going to allow us to get to those actions that are so critical to decrease gun violence in communities all across the country. And of course, we're hoping in the first 100 days of this new administration. If you need more information or would like to learn a little bit more about what Brady is doing, please go to bradyunited.org. And you can also follow us on Twitter at BradyBuzz. And thanks so much for joining us, and look forward to seeing you in the future. Bye-bye.